If you have any question, you can ask him through his Instagram account or his website or email. Dr. Nazari is a specialist in field of microscopic dentistry and direct restorative dentistry. In 2010, he created the Microvision Academy and started organizing courses for dentists on topic tooth preparation with microscopic for full crowns. 2011, he started organizing new courses on topics of photo and video documentation in dentistry, microscopic approach, total rehabilitation from A to Z, and direct restoration from macro to microvision. Usually, his clinical work 70%, lecturing 30%, by now conducting more than 400 presentations worldwide. He visited over 60 countries sharing knowledge with other dentists. He's the founder of Microvision Clinics and Microvision Lab. He's the co-founder of Microvision Group, runs a family clinic in Ukraine. So let's enjoy the Microvision protocols for smile makeover through the video. Thank you very much.
Days I'm mostly doing the prosthetic work. Nowadays, 80% of the work that I'm doing are full mouth reconstructions, and about 20% of work I'm doing are smile makeovers, like one full arch after orthodontic treatment, like more aesthetic smile makeovers. You know, it would be very difficult to be a great prosthodontist if you don't have a great team. And we all know how important it is to be able to cooperate with a very nice dental technician. In my case, my dental technician is my father. I'm very honored to be able to cooperate with my father, and he is a very open-minded person. So, in his professional life, he was doing metal crowns, then he was doing metal plastic crowns, then he was doing metal ceramics, then press ceramics, and then he switched to the digital when I asked him, hey, let's go digital. And now, as a team, of course, we can reach and manage more clinical cases. There is a big discussion on the market, digital versus analog workflow. And today we're actually going as well to speak about this. I was working many years, I would say almost like 8 years with the analog workflow. We had great results. Now, about 6 years ago, we switched to the digital workflow. It's completely different comparing to the analog workflow. Again, I will share with you our steps of the digital workflow, but I would like to start actually from the analog, and I would like to share with you how we plan the case for each patient and how we accomplish those cases. So this patient, Irina, she came to my office because she was not really happy with her smile. I mean, on looking at these portrait pictures, you can see that she's smiling, not too confident. When we look at this video recording of her smile in dynamics, we can also see that she has some rotation of the lateral incisors. She also has some gaps, I mean, in between the central and the lateral. And when she smiles, she still has some space from the incisal edges of the upper teeth to the lower lip. So basically, we understand that we have some space to elongate those teeth because the request from the patient was to make the teeth slightly longer, to close the gaps, and to make the smile slightly more refreshing, but maximum natural. And this is what we are going to do for our patient. So what we would do in the analog workflow, I would go ahead and I would use the digital smile design. I would use the keynote, and in a 2D format, I would plan what I want to modify for my patient. I would show to my dental technician, hey, listen, please add 0.7 millimeters to the incisal edge of the canine, or please go ahead and add 0.8 millimeters to the incisal edge of the central. And this is how I would guide my dental technician during the wax-up procedure, because otherwise they don't have any information from us as clinicians. And the keynote and simple tools like digital smile design over here gives us a possibility to improve communication with a dental technician. Again, the dentist is the person who is first of all responsible for the clinical outcome, and we need to guide our team to reach the best possible results for our patients. So once the DSD design is done, I would send it to my lab, and my lab would perform the wax up. Yes, this is what we did in the analog. We would do the wax up according to the DSD. And then I would just use the honeycomb from the DMG to make the silicone key, as you can see over here. Then I would trim the silicone key nicely on the margins, you can see here, because I don't want to have any bisacrylic on the surface of the soft tissue. I want it to be maximum precise and nice when I show it to the patient. And then I would transfer it to the patient's mouth to show the picture before and with the new possible smile. And this is how we would motivate our patient for a treatment, because people, they need to understand how they are going to look in the end of the story, because otherwise they don't know why they need to make this step for a treatment. They don't know, maybe they're gonna look worse than before. But with the mock-up, we can show them and it looks quite naturally. I mean, I like to use Luxatemp. It looks beautifully in the smile of the patient, as you can see right now on the picture. And now you can see that we closed the gaps, we slightly elongated the teeth of the patient, and the smile looks natural. I mean, the distance to the lower lip now is not so open. The teeth are closer to the lower lip. The curvature is natural. And of course, the patient agreed for the treatment. So now when we speak about the modern concept in the planning phase, we would of course start from the photo video documentation. As you remember, in the photo studio, I mean, the photo studio is a must-have nowadays in dentistry. I'm sure many of you have photo studios in your offices. Then we would go ahead, we would make the DSD planning for our patient. I would send all this information to the lab to perform actually the wax up. Once we have a wax up, we can go ahead, use the Luxatemp, use the honeycomb, and transfer the prototype to the patient's mouth. We go again to the photo video studio, we take some beautiful pictures of our patient, the portrait pictures from the front, from the side, and we put together for her presentation quickly in a keynote, as you can see right over here. And then I would just show it to the patient, explain to the patient what actually we are going to change and how we're going to do this. And then I would usually get the agreement from the patient side. Once I have the agreement from the patient side, I can go ahead with the next step and actually transfer the mock-up one more time on the next visit before I start the micro-invasive preparation. I would use completely same silicone key that I used at the first day to motivate the patient. I would use the Luxatemp. Usually I like to use either B1 color or bleach, depending on how much I'm going to change the color of the teeth. So once the smile is transferred, I can go ahead with the next step. And the next step is actually creating a split dam. I want to create comfortable conditions for myself to work as a clinician. So I would go ahead, take the rubber dam, I would make the 3 holes in this rubber dam. And after this, I would just go ahead, put 2 clamps on the molars, as you can see over here. Yeah, and I would use the obite to close the palatal, because I don't want to have the gap on the palate. I don't want saliva to go in the patient's mouth. So once I created nice excess, once I transferred the mock-up to the patient's mouth, I can go ahead and start with a micro-invasive preparation, because now I can use the reverse technique. Now I have the final volumes, and according to the final volumes, I'm going to use the depth cutter to start with my preparation. What's really important when we start working with the patient is actually ergonomics. So using the microscope, we have a possibility to have a beautiful ergonomics, mostly sitting in 12 o'clock position behind the patient, as you can see on this video. Sometimes I can move to the 9 o'clock position this way over here, only to work with the 4th quadrant in the patient's mouth. But 90% of my time, I'm using 12 o'clock position with my patient, and this is how I perform all of the preps, not only all the preps, but also how I did the impressions or retraction or any steps in the prosthodontic treatment of my patient. So this is how I was working, and this is how it looked from the side. Now let's have a look how actually it looks intraorally, and this is what I see as a clinician when I work with my patient. So again, transferring the mock-up, waiting about 30-40 seconds until Luxatemp sets. I remove the excess of the material, as you can see, and then waiting a few more minutes, I would remove the silicone key. Yes, and this is how the mock-up would look on the surface of the teeth of the patient. After this, I would just go ahead, I would put the split dam, I would put the clamps on the teeth, I would use the frame, and then I start with the preparations. I'm using the depth cutter, 0.2, 0.3 millimeters. I want to be as minimally invasive as possible, and of course I want to work only within the enamel, because we all know that the predictable bonding is only when we work with the enamel. So 0.2, 0.3 on the surface reduction, and then when we speak about reduction on the incisal edge, it's about 0.7, 0.8 millimeters. I'm always facing the burr to the mouth of the patient so the water is not flowing into my microscope. After this, when the depth cuts are done, I would go ahead and carefully remove the bisacrylic from the surface of the teeth. Use a little bit of the floss to clean it in between the teeth, as you can see. And then what we can see, we have only very tiny signs on the surface of enamel that we need to prep. My goal on this stage is also to remove all of the sharp transitions. Little bit more we had to prep the lateral incisor because it was sticking, it was slightly rotated, and then I would just smoothen all the sharp transitions on the canines because we don't want those stress points for the ceramics. Because of these stress points in future we can have problems with the cracks. And then once I would finalize with the preparations, if you pay attention, the before shaping and the after shaping, the shape actually did not change a lot. I mean, the preparation was super minimally invasive. I just smoothened some transitions. I removed very tiny little of enamel on the laterals and also on the centrals. And for this specific patient, to be honest, there was no even any need to make the provisionals because she didn't have any sensitivity. We didn't expose the dentin in any of the points. So then we can go ahead and analyze that. The modern concept when we speak about the preparation, we would go ahead, we would take our mock-up, transfer it to the patient's mouth, we would go ahead, we would apply the split dam, we would use the microscope because we want to be as minimally invasive as possible. I was using my micro-invasive kit for preparation that I did with Comet, is for veneers and the onlays. I would prep through the mock-up, remove the mock-up, finalize with the preps, and then I would go for the final step, that is actually impression. And I would use the honeycomb from the DMG because for me it's one of the best materials, and this is the material that I use daily when I was doing the analog workflow. So first what I would do, I would use the 3-0 cord, 000 cord. I would gently put it into the sulcus of the patient, cut the excess. And this is again the power of using the microscope. You can see the details very, very close. So you don't hurt the soft tissue. You go right as much as needed into the sulcus because you don't want to hurt epithelium. You remember that? Then the next step, I want to make sure that everything is super dry. I don't want to have like any saliva or any other problems on the surface. And then I would go ahead, I would inject some impression material very slowly, make sure it goes into the sulcus on the centrals. No rush, the material gives me plenty of time to work, and this is again why I love it a lot. I apply it everywhere on all of the surfaces of the teeth, as you can see. Additionally, what I like to do, I like to use some air to make sure I spread the material nicely, evenly on the surface, as you can see over here. And then very slowly, I would insert the putty material. No rush. Wait, take it out, and analyze with the microscope. So what is the goal of using the cord is actually to get both vertical and horizontal retraction. Most of the cases I use one cord, but when I have a deeper type of preparation, then of course I need to use two cords. So it's 000 in the sulcus and the 00 on top of it for about 4 minutes. Then I would remove it and then I would take the impression. After this, once the impression is done, I will go ahead and additionally I would use the O-bite to register the maxilla position with the face bow, as you could see. Then we transfer all that information to the lab, and in the lab we start producing the final restorations. When we speak about the ultra thin veneers, like in this specific case, my choice are actually feldspathic veneers, because they can be very thin when we speak about the analog workflow, and then of course can be maximum beautiful when we speak about the aesthetics. But again, to get beautiful result like this one, we need to have a very great dental technician. So they are very thin, as you can see, 0.2, maybe 0.3 millimeters. And the next step, I can go ahead and continue with the bonding procedure. And for the bonding procedure, of course, we are using the rubber dam because we want to have the full control during the bonding phase. We want everything to be super dry. I want to see the margins nicely. So I would use also the clamps, brinkers, the before. I would retract the soft tissue to make sure I visualize nicely the margins. As you can see right now, I was using also the sandblasting. Why? Because I needed to remove a non-prismatic enamel layer from the surface. Because you remember, I was prepping only very little bit on the surface, and some of the surfaces I was not even touching. And then I would just go ahead with the etching on the surface. And I really like to use Vitique from the DMG because it's a great cement. It gives me a possibility actually to check the color before bonding. So I will go ahead, I would apply the adhesive system. I would use also the Teflon tape on the neighbor teeth, as you can see right now on the video. I don't want my tooth to stick to the neighboring tooth during the bonding procedure, as you can see. I would use some air on the surface to make sure it's the even layer of the adhesive system, and then I would apply the composite material or the resin cement on the surface of the veneer. I would go ahead, check with the probe the precision of the positioning of that veneer, and then once I know that the precision is good, I will go ahead, I would clean the excess, and then I would start with the light curing procedure. Clean carefully, no rush. When I'm bonding very thin veneers, I always prefer to do it one by one. Why? Because if you put very thin veneers together and you slightly push, then you can receive a crack in the structure of the veneer, and we don't want those problems. So this is why when the restorations are super thin, I prefer to bond one restoration, clean everything nicely, and only afterwards to bond another one. So when we speak about the modern concept in isolation and bonding, I would put the two clamps, then I would go ahead, I would apply the rubber dam, I would perform the inversion, as you can see. If needed, I can also use the floss, but I would put the knots on the palatal side so they don't interfere with the margin. Additionally, I would go ahead and sandblast the teeth. I would use some Teflon tape on the laterals, as you can see. I would put the clamps, then I would try the insertion path for the ceramic restorations. Then I would bond them, I would polish the transitions, and then I'm done with the bonding phase. So after this, we can actually analyze how we started with the smile of the patient at the beginning. You remember, but we had this distance in between the incisal edges and the lower lip. And then we would go ahead, we would show the mock-up to the patient, we would slightly elongate the teeth, we would get the agreement from the patient. And here is how we would finalize actually the smile of the patient with a beautiful feldspathic restorations. The intraoral picture, you can see that the soft tissue looks beautiful. Even the microscope images show very nice integration of the ceramic restorations and the soft tissue. And what matters for us the most, of course, is the portrait of the patient. Please pay attention right now on the smile, on the before picture and on the after picture. So now this distance from the upper to lower lip is more filled with a tooth structure with the new ceramic veneers, and the smile of the patient looks beautiful. But of course, what matters the most is not just the result the day when we bonded, but also what happens after. So here is the case before, how we started, and here is the case 5 years later. I mean, the patient has the beautiful hygiene, the patient is visiting our office every 3 months because this is the rule for all of our patients to come for a checkup every 3 months. So we do the professional hygiene, we also analyze the condition of the restorations. And here is the final smile of the patient 5 years later. And of course, the happy patient and happy doctor. But you know, the analog was beautiful. Of course, it was beautiful. We did many beautiful cases, but then I understood that the world is moving and we need to move on and progress as well. And I decided what's going to be the next step and why. My goal actually was to try to work less, produce more, and be able to enjoy life. So now I would like to talk to you about a few things like improved patient communication when we speak about the digital workflow, the next level clinical app cooperation, the way how we now perform the treatment planning when we speak both about aesthetics and about the function. We will speak if it's possible to make the full mouth reconstructions with the new digital approaches, and if this protocol is actually repeatable. That's what's important, of course. First of all, let's speak about the patient communication. Now, every single time when the patient would come to our office, we would invite the patient to photo video studio, we would take some pictures, make some videos, and then I would go ahead and I would scan the patient. So in a few seconds, usually to scan the uppers and lowers, I would need maybe 1 or 2 minutes. I would go ahead and create a 3D copy of the patient's teeth. And then very easily on the screen, I can show to my patient actually how his teeth look, what are the problems. Maybe there are some problems with the position of the teeth, maybe there are some problems with the caries on the teeth or some other issues. And it's very understandable when the person sees all this information in the 3D. Another great benefit when we speak about the communication and cooperation with the patient is the possibility to copy nature. So now every single time when we see the patient coming to the office and we can see that actually the patient has really nice tooth structure, we would go ahead and scan those teeth. Why? Because we can use them as the library in the future. And this is very great benefit, because if we have these natural libraries, we can use them for the future clinical cases. So that means that we can create maximum natural new smiles for our new patients. Or for example, when we have the older lady who comes to our office and she says, well, I had teeth when I was young, just like my daughter has right now. So for us, it's not a problem. We can just invite her daughter to the office, scan her teeth, and use them as the library for her mom. These are the beautiful and great possibilities when we speak about the digital workflow. So we can say nowadays that when we speak about the digital dentistry, there are no limitations. With the digital dentistry, we can make small cases, we can make aesthetic cases, and we can make cases on implants. Whatever we can imagine, we can do it nowadays with the digital dentistry. We have even more tools than we had with the analog workflow. Now, about the next level clinical lab cooperation. Well, the big revolution happens even not so much in the dental office as in the dental lab. I would say the change in the dental office is about 30%, but 70% revolution is in the dental lab, because now everything is completely digitalized when we speak about the modern digital lab. And of course, nowadays they start using these new tools like CAD/CAM, like printer, like intraoral scanners, and this completely changes the workflow, completely from A to Z. So if we compare how we did the cooperation with the clinical lab in the past, so we would go ahead, we would take the impression, we would send this impression to the lab, but sometimes the lab can be really far. For example, my lab right nowadays is 700 kilometers away from me. So I would need to send the impression, and of course it's more complicated. Then they would receive it, they would make the gypsum model over here, they would prepare the gypsum model, then they would go ahead, either CAD design or they would make the wax up for the final restorations, and then once the restorations are ready, they would need to send them back. It all takes time. And you all know it when we speak about the analog workflow. When we speak about the digital workflow, now it's different, because once I finalize prepping my patient, I would go ahead, I would quickly scan him, and with the push of the button, in 1 minute, my scan would be already in the lab. And it's super quick and super fast. And it doesn't matter that my lab is 700 kilometers away. This is amazing possibility. And then they would make a case for me and just send it back. Or we have another option, the option number 3, where actually we can have a small, tiny digital lab inside of our office. So it's super comfortable. I scan the case, I send the case to the next room where I have my digital lab technician. He does all the work, he mills it, he stains it, and gives it back to me. So this is definitely the future of dentistry, those in-house labs. So let's see how actually we would do a case when we speak about the new protocols. First of all, we will start with the future smile discussion with the patient. We will make the photo video documentation, the face scanning, the intraoral scanning, the diagnostic occlusion analysis. And this is very and very important. Only with the proper planning we can receive a beautiful result for our patient. So let's have a look at this patient. Her name is Vlada, and Vlada came to our office because she wanted to improve her smile. It was like super wide, it was not natural. So we went on with the face scan. As you can see, we did the intraoral digital scan. We also made the CBCT. So we collected all possible information that we need potentially for our planning of the clinical case, as you can see over here. So it's not like it was in the past that the dental technician was supposed to look only on the articulator. We basically create identical digital copy of our patient that we can send to the lab, and now our dental technician can actually see the person that he is creating the new smile for. And this is crucial difference comparing to the analog workflow. Also on the right, you can see the CBCT, the exported STL files from the CBCT, and we can see how much tooth structure is left underneath, because the patient has plenty of composite veneers crowns right now, and with the CBCT we can analyze and understand how much tooth structure was prepared by the previous clinician. And now I know what to expect once I start removing those composite veneers from the patient's teeth. So here we can actually see and analyze the condition in the patient's mouth. We can see those plenty composite veneers, and as I just said previously, we can also see the recessions right over here, right over here. And if you pay attention, the zenith difference is huge. I mean, look at the canine on this side and look at the canine on this side. I mean, there is a huge difference. So of course, my goal will be also to correct the soft tissue on this side, because I want to bring the zeniths on the other side on the same level as in the first segment. And we also see that we need to cut a lot in this zone. So we understand that it's not just a gingivectomy. I will also need to work with a bone level, because otherwise I'm going to violate the biological width and it's not going to work properly. Again, the planning starts already on this stage. The lower teeth, I mean, similar story. You can see lots of bulky composite that completely doesn't look natural. She has this diastema between the two centrals. She has also inflammation of the soft tissue because the precision of those composite veneers is not good at all, as you can see in this clinical case. Let's see at the occlusal view. I mean, same story, just white, bulky composites. It's a pity, but nowadays we see a lot of cases like these ones, a lot of cases where there is no proper anatomy, a lot of cases where there is no good precision, and as the problem, many perio problems for the patient, like inflammation of the soft tissue, as you can see in this specific case. Once we get closer with the microscope, we can also see this, I call it composite balcony, where actually all the bacteria can stay, and this causes the crucial problems for the patient's health. So what we do next, we took all the pictures, we scan our patient, and by the way, nowadays we can say that with the scanners, we have this new experience for our patient. It's something completely new, no need to create some uncomfortable movements in the patient's mouth. We have a very high digital accuracy. We can save lots of time, and we can see, of course, more patients during the day. There is no need for shipping as with the impressions. And of course, there is no cost for the storage. I mean, we don't need to save gypsum models anymore. Everything is completely digitalized. I send this information to the lab, and now, not like in the past, my CAD designer doesn't need to cut away the volume from the gypsum model and start waxing the new shape. He can just go ahead and use the CAD software. In a combination with those intraoral scans, He is also using the portrait pictures of the patient, and also you will see he is using, in addition, the face scan of the patient. And then he can actually see how he is changing the smile of the patient. As I told you previously, we have many libraries, many digital libraries of the natural teeth, and we can just go ahead and go through those libraries and choose which ones work the best for our patient. And we can see it really nicely because we also see the face of the patient. Sometimes we can try a few different libraries and comparing to the analog workflow, where usually the wax up for the uppers and lower teeth would take at least 1 day to make it properly aesthetically but also functionally. When we speak about the digital workflow, the possibilities are completely different, because now we can create the beautiful design of the patient in 2-3 hours, and both it will be aesthetic and functional. We can see all the details in the 3D, as you can see. Also, I asked my cut designer, please design that second segment, I mean the canine and the premolar, go on top of the soft tissue, so I will have a guide how much not tooth structure, but the soft tissue I will need to correct. Then what he does, he is now eliminating the volume of those composite veneers on the lowers, and then he will also choose the library for the lower teeth so they look maximum natural once we finalize with the treatment. And again, these new tools, they are just incredible, because once we finalize with the design, we can go ahead and send information to our Asiga printer, and Asiga starts printing the models really quickly. And nowadays we use printers for everything. We can print models, we can print deprogrammers, we can print surgical guides, we can print preparation guides, we can print provisional restoration, everything. So now once the printer is working, the dental technician can be focused on different things. He doesn't need to stay and just work with one model like he did in the analog workflow. So what we printed for this patient? We printed 3 types of models. First one is a motivational model that actually goes on top of the soft tissue. I will use that model to control the soft tissue correction. Another model is 2-in-1 that actually has the present future design and the present design of the teeth shape. And the third kit of the models is actually the future final design that I will use actually for the provisionals for my patient. So what happens next? I go ahead, use my honeycomb, putty, and the light body material. I want to copy actually the printed models, and I want to make the silicone key so I can transfer all the information to the patient's mouth. First, I will use it, again, as I told you previously, to make the soft tissue correction. And then once I finalize with the preparations, I can use it to make the provisionals for my patient. So very gently, I want my silicone tray to be as precise as possible on the margins. You remember, I don't want any bisacrylic to be on the soft tissue. So I usually do these procedures before patient comes to the office, because I don't want them to wait in the dental chair. So I would go ahead and under microscope with the blade, I would cut, as you can see, the excess of the silicone. And then once everything is ready, I can start with the next step, actually the preparation process. So I want the preparation to be, first of all, atraumatic. I don't want to cause a lot of trauma for the soft tissue. This is why, again, it's important to use the microscope. The soft tissue respect is mandatory when we speak about the preps. In addition, I already understand that there was a lot of preparation, so I want to be as minimally invasive as possible. I perform analysis with the microscope again. I want to understand what to expect now during the preparation phase. And again, we can see lots of imprecisions. And I mean, this is what usually happens. If people don't use magnification, they just miss those things, not on purpose, just because there is a limitation of vision. This is why I want to say one more time, using microscope is mandatory, because then you can nicely see and control all of the details during the clinical workflow. So visual control is number one possibility that you must have during all of the steps of the treatment. Precision of all moves. Make sure, again, you don't cut too much of the tooth structure. So on this stage, my goal was just to eliminate and remove the composite material, not cutting any tooth structure. The tooth structure I will correct on the next stage of the preparation. So speaking about the margin positioning, when we speak about the static cases like this one, I would prefer my margin to be 0.5 millimeters in the sulcus. Why? I want to stay 0.5 millimeters usually away from epithelium. I don't want to violate the biological width. This is super important. When we speak about the posterior zone, I would usually stay on the level of the soft tissue. There's no need to go deeper in the sulcus because first of all, it's visually not visible when we speak. And then when we speak about the molars, I would even go ahead sometimes stay super gingivally. So then it's super easy to perform preparation of the teeth and also to scan or take impression if you work with the analog workflow. Usually the reduction of the full arch composite would take about maybe like 2 hours, I think. Sometimes when we're working with 14 teeth, it would be even to 3 hours, sorry. I mean, preparation, retraction, scanning, I mean, all of these steps. So once I finished eliminating this volume from the surface of the teeth, this is what we received. I mean, listen, sometimes people are saying the composite restorations are less invasive than the ceramic restorations. Well, seeing this image over here, we can make a conclusion that it's not so much about the material that you choose for the final restoration. It's probably more depending on the operator who is doing the case, because in this case, they were very invasive and honestly, dentin, as you can see, was exposed in many zones on the tooth structure. Now, the next step before I go ahead with finalization of preparation, I would go ahead and need to correct the soft tissue. So what is amazing, I get these screenshots from the lab and I can clearly see how much soft tissue I need to cut to make the zeniths equal on the both sides. So here in the cross section, I can see that it's 2.6 millimeters on the canine. Perfect. So now I'm completely informed by my dental technician. I would go ahead, I would use that motivative silicone key. You remember I told you about, we have a motivative model. I would use some Luxatemp. I would transfer that information to the patient's mouth. Again, wait a few seconds until it sets. I would remove the excess. Then I take out the silicone key. And now what we can see in this video, how much we actually covered the soft tissue with the bisacrylic, because yes, this is our plan, how we want to finalize with the future ceramic restorations. So before doing any correction on the soft tissue, I would go ahead, I would use the probe because I want to make some reference points on the surface of the soft tissue with the probe. And then once I have these reference points, with the curette, I can gently remove the bisacrylic material, and then I can just go ahead under control of microscope, use my electrosurge. So on the lateral incisor, I just needed to make some minor corrections, so it's just a simple gingivectomy. So no need to go ahead and do any crown lengthening after this. But for the canine, as I told you previously, I need really to cut a lot because we really needed to go higher with the future zenith position. The premolar zone as well was enough just to go ahead with the gingivectomy, as you can see, because it was quite minor correction. First premolar and also the second premolar. After I finalize with the gingivectomy, I like to go ahead and just use some fluoxetine to clean the surface. But then I'm not doing right away the crown lengthening. I would go ahead, I would continue with finishing the preparation. Then I would do the final scanning and then gingivectomy only after the final scanning. So there is always a big discussion, like what I like to use more, the Luxatemp or the Luxa Crown. The thing is, if I have stages like this one where I need to easily insert the material, but then without any big trouble to remove it, so it's a short-term material, or when I make the provisionals for a patient for just 1 day, then I would use the Luxatemp. But when I have a case and I need the patient to be with the provisionals like 1 week or 2 weeks, or maybe sometimes even a month, so in those cases, of course, I would prefer to use the Luxa Crown material because it's very strong. You can polish it nicely and it can work for way longer in the patient's mouth, and you are confident that it's not going to break. So then I would go ahead and I would perform the retraction 3-0 cord in the patient's mouth with the viscous tape because I don't want any bleeding during the procedure of the preparation. And then my goal using the red burrs is actually to reposition the margin to the patient to the new level of the soft tissue. Under control of microscope, again, just using the red burrs, so no need to use any more the aggressive burrs on the surface of the teeth. Very carefully, just smoothing all the transitions and repositioning the margin, as I said previously, to the new level of the soft tissue. Carefully, lots of water cooling because we don't want to overheat the teeth. We don't want to cause pulpitis for the patient. And then the next step, once I'm done with the preparation phase, I can go ahead and perform also the scanning procedure. In addition, you can see I'm using the retraction paste from the DMG because it helps actually to create maximum dry surface on the sulcus. This is one of my favorite tools that I use for many patients because then we don't have any bleeding, we don't have any saliva, the surface looks nice and clean. I would use the retraction paste and leave it there for about 3-4 minutes, then clean everything nicely with the water, air dry, and then I would just go ahead and scan both the upper and the lower teeth. So first visit, I prep and scan the upper teeth, and then I would bond the upper teeth, and then I would continue with the same steps for the lower teeth in the next visits, as you can see. So creating now the digitalized copy of my patient, so then I can send all this information to my CAD designer. So this is how the final preparations would look. You can pay attention at the zeniths. So now we went up with the canine over here, and the same with the premolars to make sure that we are on the same level or maximum close with the first segment. Then during the scanning procedure, I would additionally use the flowable composite in the anterior zone, so to make sure that the patient is not going to move the mandible anywhere. Before starting the crown lengthening, I'm also analyzing the CBCT of my patient. It's really nice because there is a possibility to export the CBCT in the STL files and to understand what is the thickness of the buccal bone, because I'm planning right now to make the flapless crown lengthening for my patient, so I don't want the bone to be too bulky. Well, in this case, to be honest, the bone is a little bulky on the canine, but still I decided to go ahead and not to raise the flap. So this gives me a possibility to finalize the case quite fast. So I'm using the Brazilian device that is called the CV Dentus. It's a piezo device, so it has a special tip for the crown lengthening. The working part is about 3 millimeters. So I go all the way down until all the working part is in the sulcus. So in that way, I understand that I removed 3 millimeters of the bone. So we have enough space to have the new biological width created in the future. And then I use just a spot bond and spot etch spot bond technique, so I can make the provisionals for my patients so they stay there firmly. I use, in this case, the Luxa Crown, as you can see, because I want them to be very stable and not break in the patient's mouth during the provisional phase. And then I remove the excess I transfer the material with my silicone key. I take out the silicone key. Now I can go ahead and actually correct it with the burr carefully. I want to make sure that there is no excess of the material on the soft tissue, because otherwise after crown lengthening we can have some big problem if the material goes into the sulcus. And then you can see we did the correction, and then we send all this information to the lab. In the designing software, my CAD designer is defining the margins. So it's super nice because actually the CAD design software is like a microscope. Our CAD designer can increase as much as possible the magnification, and he can see everything. You can see it right now on the video. So it's really important to make really nice retraction when we are doing the scan, so then the CAD designer can see all of the margins perfectly around the teeth. And then we are using the same library that was used for the motivation of the patient, as you can see over here. And so we know that it's a copy paste, the before and the after. I mean the before when we speak about the motivation, because this is what patient accepted. And you know, this is the limitation often of the analog workflow, when we show them the wax up, but then the final result is not completely the same and the patient maybe is not so happy. But in the digital, we don't have those type of problems. Once the final design is ready, we would go ahead and we will start with the milling process. So we are using the M-press blocks, and our Roland machine is producing beautiful precision on the margins and also great macro and micro texture. This is what we now can actually receive from the milling machine. So what is amazing that nowadays when we go ahead and design those restorations, we get completely same shape that is milled. That's the point. And this is really, really beautiful. Usually the milling process takes about 20 minutes for one restoration. And then once the milling process is finished, we can go ahead and start with the next step, is actually finishing the restorations before starting with the 3D staining. So now my CAD designer is actually cutting them from the block. He's gonna do the finishing on the surface. He's gonna make sure all the margins are nice and clean, as you can see over here. So the connector is being cut very gently under control of microscope. All the procedures again have to be done with magnification because we want the precision of the restorations to be top. And then he's using the rubber to cut the rest of the connector from the outside of the restoration, as you can see here. And then once he's done with the polishing, now my father starts with the final stage that is called the 3D staining. So nowadays when we speak about the digital workflow, we are not using any more layering. So we were not doing any layering the last 6 years in our practice. So it's only polishing and the 3D staining, superficial. We do not want to change that natural morphology of the teeth that actually we received from the milling machine. This is the main and great benefit of the digital dentistry, the natural morphology. So just little stains on the surface and that's it to create nice and natural look. So these are the monolithic restorations with some 3D staining. And after this, I'm ready to go ahead with the next step, is actually the preparation of the restorations for the bonding procedure. So I like to use this veneer me device, as you can see, so I can put right away all of the restorations on the surface, and I can use the fluoric acid to etch them. These are M-press restorations, so I would etch them about 60 seconds, and then all at once I can clean them. So I don't need to etch the restorations 2 by 2 by 2. So it's a really time saving to use this type of the device, and I truly recommend you to use this one in your office as well. Also, all of the preparation for the restorations I do before the patient comes to the office. Then once the restorations are ready, the patient comes in. As you can see, I go ahead, I make the anesthesia. I would just break off carefully the provisional restorations. As you can see, clean everything nicely. And always before the bonding, I would do the trying procedure. I would put the restorations in place. I would show it to the patient how it looks, the trying paste, clean everything nicely. And only when I received the agreement from the patient side, I would go ahead and I would start with the bonding procedure. We will go ahead, apply the adhesive on the surface of the teeth. I would apply also the resin cement in the ceramic restorations. We would put them in place. As usual, the Teflon tape on the neighboring teeth. As you can see, we have some excess of the material. We clean it nicely. Then we would go ahead with light cure. In these cases, you can see we have thicker restoration because there was more invasive preparation done before us. So this is why I can actually go ahead and bond 2 restorations at the same time. And then finishing with the polish and the transitions. I want to make sure that the transition from the ceramic restoration to the tooth is seamless, as precise as possible. So analyzing what procedures we will do to the tooth: sandblast 10 seconds, 27 microns, etch with a 35% orthophosphoric acid, and then I would go ahead, I would apply adhesive, use some air on the surface, don't want to have a very thick layer of that adhesive. Then when I put the restoration with the composite in the place, I would have a 1 sec pre-light curing, then clean everything nicely, and the final light curing from the different sides. And then when we speak about the restoration itself, I would go ahead, I would etch it with a 9.5% fluoric acid, about 60 seconds, as I said previously. Then the patient would come to the office, I would do the trying. After the trying, I would etch it with 35% orthophosphoric acid. And then I would go ahead and I would apply a Silan for about 2 minutes, because the Silan improves the adhesion, as we all know. I would air dry additionally the surface of the restorations, apply the adhesive, use some air, and I do not light cure anything until the moment I know that everything is in place. Then I clean, and only after this I do the pre-light curing, clean additionally, and then the final light curing. Then I polish. I want to make sure that in these transitions over here, there is no overhanging of the ceramics or any gaps. I want everything to be seamless and as precise as possible. So here is the before and after. The upper teeth, this is how we started and how we finished. The lower teeth, and the 1 year after the intraoral picture of the final restorations. So nice and healed, the zeniths on the same level. As you can see, we used the B1 color Empress for this specific patient. She wanted the maximum natural result, as you can see. And of course, we analyzed it all with the microscope. We can see that the soft tissue is nice and stable, no inflammation, everything looks beautiful. And of course, in the end of the story, we record a final video with our patient. She is super happy with the results, and I'm happy as well, because we managed to reach maximum natural results. They are not too wide. We use the natural shapes of the teeth. This is actually the great benefit of using the digital workflow, because the shape that you see is not created by a human. These shapes are created actually by nature. And to finalize the case like this one, we need only 1 week. So in 1 week, we can easily make 20 or even 28 restorations for our patient. And it's completely possible using the digital workflow. So we also published this clinical case in the Journal of Aesthetic and Restorative Dentistry, and you can easily go ahead and download if you want to find out more details about this specific case. If you want to learn more about the digital or analog dentistry and the workflow, you're very welcome to our website, and we have a beautiful online course that is called Analog versus Digital Dentistry. So it's mvision.pro. You can just go ahead and register and watch all of the nice videos that we prepared for you. Or if you want to go ahead and have a hands-on course with us, you are very welcome to our new training center that we launched in Las Vegas. It's called Envision Las Vegas. So we organized all the best possible equipment for you. We have microscopes, we have the typodons, we have the Swiss instruments, the face scanners, the intraoral scanners. Everybody is actually experiencing a clinical workflow. We have a live demonstrations on the patients. Everybody is going to work with the beautiful technology. We teach about the digital occlusion using Mojo. I mean, everything that you can imagine for perfect training, we actually organized in mVision Las Vegas. Plus, Las Vegas is not the worst place in the world. It's a very beautiful place to visit. You are very welcome. Just check the website and you can find all of the details. For me, it was a big pleasure to present for you. I hope you enjoyed the presentations. This time is online. We hope in future we will meet in person definitely. And I just summarizing my presentation, I want to tell you one thing. Now I know 100% as a Ukrainian that life is very limited. It's not super long. So I would like to recommend you and to advise you to remember that life is not only teeth. I want you to find a balance in your life and to work less, produce more, and of course, enjoy your life. Thanks a lot for your attention and enjoy the event.
We thank Dr. Nazar for his lecture, and we're starting now with Dr. Hadi for his lecture.
بسم الله الرحمن الرحيم. حياكم الله بمؤتمرنا ومشكورين على وجودكم معنا. I welcome you all to this conference and thank you for being here with us. Today our speaker is Dr. هادي البحراني. طبعا دكتور هادي غني عن التعريف، زميلي في مستشفى الأميري. Dr. Hadi got his DDS from Virginia Commonwealth University and Master of Science in Dentistry in Boston University, Certificate of Advanced Graduate Study, Boston University, and he is a consultant prosthodontist in Amiri Dental Center. He's assistant professor in Kuwait University and lecturer and trainer in the field of implant dentistry. We thank you in advance for sharing your knowledge with us today.
مشكور دكتورة، ما قصرتي. صباحكم الله بالخير. Good morning everyone. طبعا it's an honor ان اكون موجود معاكم هنا اليوم. I would like to thank Dr. Ayad Lemgate for his invitation to present at the KDA conference. Today's presentation is going to be related to a topic that's rarely covered in implant dentistry. I would expect that some of you here are of a specialist level, some of you are of GP level, so you come from different backgrounds. I will do my best really to satisfy all of you. Yani my presentation is not going to be so much in depth and it's not going to be so much superficial. So I did my best and I hope you will accept what I'm going to be offering you. بداية I think in المنظمين المؤتمر they have some kind of competition and they ask for every presenter to provide 4 questions. So I think you are required to answer these 4 questions. So a little cheating. The slides that the questions are will come with 2 golden stars. So أي وقت تشوفون 2 golden stars هذه السلايدز اللي راح تجي منها ال 4 questions. So take your notes. وإن شاء الله في نهاية البرزنتيشن في جائزة بسيطة تقديرية حق أحد الحضور إن شاء الله. It's going to be a simple question. اللي يجاوب السؤال إن شاء الله he's going to be the lucky guy. بداية, you all know that implant dentistry is probably one of the greatest inventions in the field of dentistry. It's beneficial for the patients, it's beneficial for the dentists. We can change people's lives with this for both the dentist and the patients. Why the dentist? This is a great money tool for all of us. You know this. However, مو كل الحالات اللي نقدمها are satisfying. مو كل الحالات they come with great results. For example, this case, we extract 2 teeth for a young female patient. طبعا بداية قبل لا أكمل I would like just a disclosure. The pictures I'm presenting you are either some of my own cases, some of them I took a permission from the owner of the pictures, some I gave reference, and some of the pictures are actually free to share. So this patient, young patient, we extracted 2 front teeth. It's a disaster for a young girl. Pointer مو شغال. However, we replaced the 2 front teeth with a very satisfying result for the patient. So that's a great success. However, it doesn't always happen that way. في عندنا حالات we fail aesthetically with implant dentistry. في حالات we fail biologically with implant dentistry. There are some cases where the patient just keeps coming every few months with a loosened screw. وفي حالات the whole system breaks on us. The point I want to mention, if you look at this picture, what do you see? A beautifully integrated implant, right? I would guess if I leave this implant buried for 5 years like that, nothing's going to happen, right? So this is what I call a disconnected implant. It's not connected to anything. So it's sleeping happily. However, once the implant gets connected to something, this is where trouble happens. So usually, most of the complications that we have come from the connecting part between the prosthetic component and the surgical components. Most of the presentation that you attend, they either talk about the osseointegration of the implant fixture to the bone, the protocols of restoration, but rarely we speak about the connecting part between the two components. So before I go further into details of the presentation, I would just give you a brief history of how the connection of these implants evolved. Probably most of you know who this guy is, right? Anyone? برينمارك, Dr. برينمارك. I mean, غني عن التعريف. In 1952, Dr. Brennemark, he came up with the discovery of the concept of osseointegration. And to your knowledge, Dr. Brennemark was neither a dentist and he was neither an orthopedic or a surgeon of any kind. He was not a physician. طبعا في معلومة خاطئة أنه هو كان جراح عظام. He was not. He was basically just a scientist. Thank you. Sorry for the interruption. Huh? Slide مو طالع. إذا ما صار خليني على البوديوم عادي. وهذا البوينتر جرب هذا. Try this one. Oh, it was working. Okay. Thank you. خلاص تمام. Yeah, I have it. Thank you. Okay, so as I said, in 1952, Dr. Brennemark, he came up with the discovery of the concept of osseointegration. And his experiment was the fixation of a titanium screw in a rabbit leg with a empty chamber at the top. And his goal was really to look inside that chamber to observe the bone healing and the blood flow in a traumatized bone. However, when he tried to remove that fixture from the rabbit leg, he found that it was glued to the bone. So this is where the concept of osseointegration came about. Now, when he discovered the concept, Dr. Brennemark, he thought that the best application for this discovery was to place fixtures in patients' jaw and restore them with teeth. Now, Dr. Brennemark was not a dentist, as I mentioned. So the whole concept of how to connect teeth of two implants was not mature at that time. So the original design was composed of a fixture with a small hex and a complex of structure that connects to the top of that implant in order to restore. The original treatment was to restore a full arch restoration. It was not intended for single restoration. Do you know who this guy is? Now you know this is Dr. Brennemark. Who's this guy? It's not the iPad question, don't worry. This is the first patient that Dr. Brennemark treated with his implant protocol. The first patient ever. Gustav Larsen, he was restored with a full lower arch implant restoration in 1965. And to the surprise, this guy actually died with the implant still functional in his mouth. Who this guy is? It's not the iPad question. Sven Johansson. This was the taxi driver who was delivering the first patient to the clinic. Who cares, right? Actually, the first patient advised this guy to receive implant treatment as well by the hand of Dr. Brennemark. So in 1967, this was the second patient who received implant treatment, and it was a full upper and lower arch implant treatment. And guess what? This patient died with the restoration still functional in his mouth, even though the treatment protocol was not mature yet. So Dr. Brennemark, he contracted with a Bofor company in Sweden to manufacture his implants, which was renamed to Noble Industries, and then renamed to Noble Pharma, and then renamed to Noble Baycare as we know it now. 1981, he presented his paper about the success of implant treatment. But it was not until 1982 when Dr. George Zybe invited him to Toronto in Canada to present his protocol. And this is where the implant protocol explosion was throughout the whole world. Very soon after, in 1982, the very smart Dr. Gerald Nesnick, he captured the idea of implant treatment. And because he is a dentist, he tried to build up on the success of implant treatment, but his main concentration was to develop the connecting part, not the implant itself. So first, he came up with this cylinder with a connecting part at the coronal part, basically to create an overdentures. And then he further developed the idea, and he made a hollow inside that implant with a component that gets cemented inside the implant, just in a similar fashion as the post and core protocol. So it was an implant with a post cemented inside the implant and a crown cemented on top of that. And he did not stop at that point. In 1986, he came up with the screw vent implant. So that was basically a fixture with a hex inside the implant and a leading bevel at the top. And that was something big at that time, really. This has allowed the restoration of single implant restoration, which was not available at that time yet. The system is still functional under the company name Zimmer Biomet, and is still very successful. Later on, he tried to develop the idea of beveling the external hex. The external hex, which was designed by Dr. Brennemark, as I said, it was not designed to receive single implant restoration for the reason I'm going to explain later. So Dr. Gerald Nesnick, he tried to taper that hex a little bit to create some kind of retention to the connecting part on top. But that design really didn't proceed any further. Dr. Kirch from Germany, in 1974, he came up with the idea of the IMZ implant and the IME element, which was basically a plastic component that gets screwed to the inside of the implant. His goal really was to simulate the idea of PDL, because implants are very rigid fixture. So he tried to simulate something that really just works as PDLs. But that design really failed, because this component was really drying out all the time, and the dentist, they had to replace it every once in a while. Dr. Schultz from Germany, he came up with his own design of implants. In 1974, he came up with this ceramic implant with a small metal post that gets cemented inside, again, just like we do post and cores, and a crown cemented on top. Now, that design didn't go any further neither, but in 1992, he came up with something really nice. It was the tube-in-tube design with a small little hex that gets fixed to the inside of the fixture. And this Fraillet 2 was renamed later on as the Zybe system. The famous Straumann implant, which is the tissue-level implant, was introduced in 1986, and it was the first tissue-level implant. The idea was to bring the whole connection away from the bone to get less problems. And this system is still functional until now. It is basically a tissue level with a conical part inside and an octagonal shape for anti-rotational feature. We're going to talk about all these terminology later on today, inshallah. And in 1985, Driscoll, he came up with the idea of using the Morse taper to the implant dentistry. Now, what Morse taper is basically once you get two metal components in a certain degree of angulation, and you get them fixed together, they create a phenomena that's called cold welding. So the two components, they will stay together even without a cement, without screw, without anything. Now, the original design was basically a cone that sticks above the implant, but he later on developed the idea, and he brought this cone to the inside of the implant with a crown attached to something that looks like a post, and it was tapped inside the implant, and it would stay placed without a cement, without screw, without anything. And that was the idea of the Bicon system, which is still functional until today. Interestingly, with the Bicon system, or the Morse taper connection, as we call it, it was noted that we get very, very, very minimal amount of bone loss around the implants. It was not understood at that time why this is happening. But today, we know why this is happening. Now, the idea of Morse taper doesn't come from Dr. Driscoll himself. The idea of Morse taper comes back from the 1860s, from Stephen Morse. And the main goal of using this concept was to fix drills, twist drills, without attaching them with anything. They would just stay there by friction. And in 1988, Dr. John Boehmer from UCLA, he came up with the first customized anti-rotational abutment. This is what we call until today the UCLA abutment. And Stig Hansen, he came up with the concept of a conical part connection that gets threaded to the inside of the implant. And this was the beginning of the Astra implant system, which is still a very successful system that we use today. So companies, they start to become creative. They start to come with all these crazy idea of trying basically to stabilize the connection as much as possible. So Calcitic, they came up with a spline implant that basically simulates the interdigitation of fingers, which should make things as stable as possible. The last historical thing that I would like to talk about, and then I will jump to more specific mechanical topics. The concept of platform switching. Do you guys all know what platform switching is? Basically, a platform switching is when the diameter of the implant is different from the diameter of the abutment. It was discovered by coincidence. In the late 1980s, implant companies, namely Nobel Biocare, it presented the market with wide diameter implants. However, the matching components was not widely available in the market. So the dentists, they needed to restore these wide implants. So what they did, they just restored them with whatever was available in the inventory. So they restored these implants with narrower abutments. But it was noted that these implants actually function better than the ones restored with a matching abutment. And Dr. Lazara in 2006, he tried to explain this phenomena, why we are not losing bone in these cases. And his explanation was that if we bring the connection even a millimeter away from the implant, we keep this micro gap, the gap that really divides the implant from the abutment. If we keep this micro gap away from the bone will be happy and it won't resorb. So as you see in this picture here, this implant has a platform switched healing abutment, and this one has a platform matched healing abutment. What we notice here, we have more bone resorption around this implant than this implant. And today, almost every implant company in the market almost uses the concept of platform switching. So our history part of the presentation is finished. We come now to the more technical part. The connection. This is the subject that not so many people talk about. This is the part that I find really is the secret of failures in most of implant cases. Now, if we talk about connection in general, like in the field of electricity, what is a connection? A connection is a female and female parts, they get interdigitated with each other to create a stable apparatus. Now, unfortunately, in implant dentistry, we didn't come to any standard of making implant connections. Like, we have what is called a USB connection, right? If you go anywhere in the world, you know what a USB connection is. So if implant company A or B or C, they all make it in the same way. Our implant companies, everyone has its own connection. So there's no standard yet. So we try to find what is a good connection. This is the first connection that Dr. Brennemark came up with. And as I told you, this original external hex initially was copied by so many different companies, and later on, every company came up with its own connection. So, if we try to categorize implant connection types, what are they? This is the first connection, the external hex connection. Now, why did Dr. Brennemark place a hex on top of that implant? For what reason? What do you think? Basically, just to screw in the implant. He had no intention really to use that hex to use it as an anti-rotation or to stabilize the superstructure or the prosthesis. It was purely made to be used by a tool to insert the implant into the bone. So, if you notice in this picture, and this is a drawing of the typical apparatus done at that time, there was a complicated cylindrical component that gets screwed to the inside, to the top of the implant. So that circular component did not have any engagement, so it was impossible to restore these implants with single crown restoration at that time. And if you try to restore it with a single crown, the crown tends to rotate around that implant. So it was not even an option to use that implant for single implant restoration at that time. Now, later on, some components, they try to come into the market with a hexed shape that matches the external hex of the implant. But in order for that prosthetic component to fit on top, they had to create somewhat of a gap. Without that gap, the component would not fit on top. Of course, I am exaggerating this amount of gap here, but it's just to explain to you what would happen if a single crown was placed on top of that implant. It tends to wiggle under function. It was not very stable. So, you can imagine if you restore a crown on a very short hex, which was 0.7 millimeter in the original implant, in the original Brennemark implant, the crown would wiggle and eventually get loosened and fail. So, implant companies, they try to improve the idea and they try to bury the connection to the inside of the implant, and this is what we call today is the internal implant. Now, theoretically, internal implant should be much more stable than external implant. But why? Why is internal implant more stable than external implant? Any explanation? Force distribution. Why would force distribution be better in internal than internal? More surface? Absolutely. Absolutely. Now, let's just imagine this, a USB connection, something everybody uses every day. If I try just to simulate this in implant, and if I put the female part in the implant and the male in the crown, or the opposite, and I fix these two together, do you think one is going to be better than the other? Not really, right? They're going to be exactly the same. So internal or external, as far as stability, they don't differ. In fact, some implant companies, they created implant connections being external or internal in the same size, same shape, in two different lines, but they would both function the same. What is different in internal implant connection is the ability that we can create a longer connection. We can utilize a bigger surface area to stabilize the connection. Now, just imagine if you try to flip this the other way around, with this long part being sticking outside of the implant. It's not a convenient way to restore this implant, because sometimes you have an angulated implant. You have to modify your treatment in whatever way. So here you have the freedom of not having anything sticking on top of the implant, but you have a deeper connection inside of the implant. So a bigger surface area. This bigger surface area should give us higher stability and retention, less risk of the screw to fracture, because we are burying the screw a little bit deeper, the abutment screw, more even stress distribution, and better tactile sensation. The longer the connection is, the better feeling the dentist has when he's fixing the parts together. Now, classifying connection, other than internal or external, we have the frictional fit connection and the slip connection. What are they? Basically, a slip connection is when you have a small gap between the abutment and the implant. This is more in parallel type of connections. This is what we have in the original Brainamark connection, external. So a slip connection is easy to fit, but it lacks stability because of this gap. And as I said, most of the slip connections are of the parallel type connections. Whereas in a frictional connection, we try to minimize this gap as much as we can to prevent movement, to prevent micro leakage, to stabilize the whole system. Another way to classify them is a beveled connection or a butt joint connection. A butt joint basically is a flat on flat, a flat abutment on a flat platform. Whereas beveled connection is we try to bevel the periphery of the implant either upward or downward, trying to create some kind of a seal. Then we can classify the abutment either being as a butt joint connection or a conical connection. I mean, you can see it's getting complicated, right? Now, butt joint connection again is a flat on flat, whereas a conical connection is a cone fitting inside of a cone. Now, theoretically or even practically, conical connection usually functions better than butt connection. Conical connection, they create a better seal and prevent leakage of bacteria and other stuff. So we agree all today that conical connection is better. It gives better seal, it gives better retention, and it gives better stress distribution. However, not all conical connections are made the same. What we see here is an implant with a conical connection, and here we see another implant with a conical connection. Are they both the same? One is deeper than the other. One is steeper than the other. So if we have two systems claiming that they both have conical connection to the implants, are they equal? Most likely yes. There are other factors. Which one you think should function better, the right one or the left one? Most likely the right one, because it's deeper and steeper. Now, there's a confusion between conical connection and Morse taper. Some companies, they claim that they have a Morse taper connection to their cones, which is not true. This company claims that this is defined as a cone. You see these two bevels being going internally? So, by definition, this is a conical connection. By definition, this is a conical connection. Now, this implant company claiming that this is a Morse taper connection. Is it? A true Morse taper connection is an average of 1.5 millimeter taper per side. or 3 degrees total. It is the kind of connection that creates retention without the need of any screws to hold the system together or any cement. Now, how many implant company has this that you might know of? 2. I know 2. Which ones? I'm not sure about the Astra. I'm not sure about the ITI neither. The 2 that I know of is the Bicon system, which holds itself together with a more stable that I showed you, which is this one. This is a true more stable connection. And the other one that I know of is the one developed by Dr. Gerald Nesnick. It's not a cone, but it's a hex. And this hex is tapered by about 1 or 1.5 millimeter. It is not retentive the same as the Bicon, for the reason that it's not as deep as the Bicon connection. But if you use this system, and if you try to screw the abutment to the implant, and if you unscrew the abutment screw, it is extremely difficult to remove that abutment from the crown without a special tool. So this is a true Morse connection. So to my knowledge, these are the only 2 systems that I know using a Morse taper connection. If there is anything or any other company using the same concept, I'm not aware of. So I talked to you briefly about platform switching and platform matching. This is the platform matching where the diameter of the abutment is the same as the implant. And this is platform switching where the diameter of the abutment is smaller than the implant. This is claimed, and it is true. We usually get better biological results and less bone resorption around these implants because of the better seal. Now, another factor is, which is not talked about so much, is the manufacturing tolerance in the process of making these components. Now, manufacturing tolerance basically is the leeway or the difference between the manufacturer part as it comes from production compared to how it was designed originally. So if we designed a gap of 0.01 millimeter, we want the outcome to be 0 or 0.01 millimeter, not any more, not any less. Now, does this happen in reality? Most likely no. There is always a manufacturing error. So companies, they try to design the best components to us, but they don't come out of production as we would like them to be. In the field of road construction, for example, we have a margin of error measured in the amount of centimeters. So when they construct a bridge, they can have an error of few centimeters connecting the parts together. But in our field of implant dentistry, what is the margin of error of manufacturing that we should tolerate, really? We would like to have a 0 tolerance. But does this really happen? Just to make you understand what I mean with manufacturing tolerance, if you see this cube being disconnected in several parts and then put all them together, just tell me how much of a gap can you see between the parts when they get fixed back together? Very satisfying, right? That's a wow, right? This is close to 0 tolerance, but it's not 0. If it was 0, you wouldn't be able to fix these parts back together. We would like to come to something close to this in implant dentistry. Now, as I mentioned, parallel connections or a slip connection is not as good as fractional connection because we usually have more of a 0 gap between components in conical connections. But looking at these 2 systems, this is a conical connection, this is more of a parallel slip connection. Which one is closed, which is open? The right one, right? This is, by the way, this is the SPI system. Now, I will try to avoid mentioning company's name if it's something negative, but if it's something positive, I would mention it. This is a platform matching connection being slipped, but Very beautiful manufacturing tolerance. No conical connection. Very bad conical connection. Dr. Zippert, he has several videos placed online. I took a permission from this guy to present some of his videos. He tried to demonstrate the effect of the micro gap, the micro motion, and what he calls a micro pump effect when implants are manufactured in different ways. So, looking at this implant system, this is an internal connection with a platform matching. No conical connection. When the whole system is put under force, and he was testing these systems at a force of 100 to 200 Newton, which is a force possibly that can happen in an average person. You can see these gaps opening. These gaps you cannot see with the naked eyes. You need a special devices like this to see. This is another system he tested where we see no gaps forming at all between the components. Now, this is internal connection, and the one I showed you before was internal connection as well. So not all internal connections function the same way. In this system, we saw a zero movement. I think I missed one thing that I would really like you to see. So once again, this is the butt joint with a platform matching, connection opening in function, something really bad we don't want to see. Here what he did, he tried to demonstrate what happens in reality, in function, in the patient mouth. When this system starts moving, he used a special radio opaque liquid, trying to demonstrate the effect of the micro pump. Do you see what's happening here? It's a liquid being sucked in and out all the time when the system is in function. This is the micro pump effect. Liquid being introduced in and out all the time. Now, what's the effect of this to the surrounding bone, to the surrounding tissue? Problems, right? All kind of problems. This has effect not only in the tissue, this has an effect to the implant components themselves. These things create corrosions, which I will talk later on. So I showed you this. Some other systems don't have any opening of gaps. And if we look at this system, it seems as everything is okay when you look at the top, right? But look at the bottom. See what's happening here. What do you see? It's dancing, right? Very nice videos, really. So even though the coronal part is being held together nicely, it's being sealed, but there is a movement nonetheless. So nothing is happening here. It's completely closed. But because the manufacturing tolerance was not perfect, the apical part was allowing for some degree of movements. Now, if we take this system and we put it under the microscope, what do we see now here at the coronal part? Abrasion. Because the system is not so much stable, there's an abrasion going on. And there are particles getting disintegrated from the system. These particles would leach into the patient's body. I will not say that's the name of this system, because as I said, I will not mention company's name if it's a negative thing. An additional topic, other than how the two platforms meet each other, is the indexing part of any system. The index goal really is to provide some kind of anti-rotational feature. It's a way of trying to fit the two components in the right way, at the right degree. Now, how many index type we have in the market? The original was the hex, right? How many connection type we have today? I would say I don't know, because every company is coming with its own configuration. Why? Why they are coming with all these kind of configurations, you think? Are they really trying to stabilize the system? Probably not. Most companies today are trying to change their morphology of the system, basically because they want the doctor to buy the components from them. It's a priority. Just like, I don't know, compared to what? Like, you know, there are so many systems in the market where you cannot find third-party components. So they try to change their connection type because they want you to go back to them and buy from them and not to go outside. Do they all function the same, you think? For the most part, yes. For the most part, but not always. Like, for example, this connection has one drawback. What is it? I think some of you will know, right? It's not the iPad question. Well, maybe, but it's not a big problem, maybe. Well, this is if you want to use a standard abutment. The main thing is it's a thick part here and very thin part here. And fracture happen usually at these weak areas. We have seen so many implant failures with the Replace Select Noble Biker. Sorry for mentioning the name of the company. I try to avoid that. But historically, this is where we found that implant diameters are, or the connection diameter is essential for the success. We try to avoid things like this, a stress being concentrated to one area. Now, one phenomena, and this is what I would encourage our surgeons to look at. It has been noticed that when implants are inserted at a very high torque, I would say something above 80 Newton centimeter, there is a tendency for these connections to deform a little bit, for some wear to happen, especially if the fixture driver is not made in a way that fits very nicely to the inside of the implant. So, in some studies, they try to compare different implant systems and see how much of a wear that would happen if the implant is placed at a very high torque, especially in a dense bone. It was noticed that in almost all systems, some degree of wear would happen to the connection part. Now, what's bad about this? Usually, if the restorative dentist tries to restore the implant, he would experience problem with the abutment moving a little bit and experience some kind of screw loosening very often. So, the message to the surgeon is, if you are faced with a very dense bone, take your time drilling. Try to create an easy insertion for that implant. Don't force things. So, after all this, what is a good connection? If you want to choose an implant system to use in the clinic, what do you define as a good connection? Is there such a good connection? I think it's the same debate as iPhone and Android. If I ask everybody here, half will say Android is good, and half would say iPhone is good. Is one really better than the other? Maybe not. If you look at the most of the meta-analysis literature, comparing different kind of implant connections, most of them, I would say most, they came up with the conclusion that all kind of connection would function the same if it was done properly by the dentist. So it's in the hand of the dentist himself of trying to make a good treatment, a successful treatment. Now, do I believe that all connections really are the same? I would disagree clinically from my own personal experience. Of course, there are some systems that are better than the others. But generally speaking, I think all systems would work. So, is there a trend in the market right now when it comes to implant connections? Yes, there is. And please note the star, which is dancing here. It's not for the iPad. Sorry. The trend now is a conical connection. This is where most companies are trying to replicate now. Being internal, platform switched, and some kind of an index, being notches or square or a hex or whatever. So almost all implant companies are doing something similar now. And this is working for the most part, for all companies. Excuse me. So going away from the connection itself, what is the single component that usually holds the system together? The screw. It's this very little small part that has a big role in the success of the prosthetic treatment. Now, an analogy that I would like to make here is between screws and post and core cement. What is holding the aperture in the post and core? Most would see the cement. The cement is holding the post and core system, right? But if the post is made poorly, would the cement work? No. It's exactly the same. The screw has a rule. But if the whole system was made in a poor manner, would the screw work? No. Now, we would like from the abutment screw to prevent a repeated screw loosening. We would like it to be of a high strength so it doesn't break on us when we screw the thing inside. We would like the screw to have an optimal fatigue resistance so it would still stay alive under function. Now, even though we would like for this to happen, screw loosening is by far the most common complication, especially in single implant restoration. And it has been demonstrated so many times in the literature. So take your note for the star. The most common complication, especially for single implant restoration, is the screw loosening. Now, how do these screws work? Now, to simplify it really, a screw would function in the same way like a spring. If you try to stretch a spring, this spring would want to go back to its original shape. So, once we screw the abutment to the implant with the right amount of torque, this screw would tend to elongate a little bit, and being held at certain points in the system, this stretching of the spring or the screw would want to bring things together. And this is how the basic function of a screw. An easier way to describe it is an elastic band. If you stretch an elastic band, what does this band want to make? It would go back. And this is how we hold things together, because it has some elasticity. And our screws has elasticity. So, in the system, if we try to apply a torque to the head of the implant, basically a rotational force, this torque is translated to a tension inside the screw, basically a stretch of the screw. Now, once this happens, we have what is called a preload. A preload is a force being built inside of that screw. And this force being inside of the screw, it tends to clamp the system together. So try to pull the abutment part and the implant part together, creating what we call the clamping force. This is as simple as I can explain it. Now, what are the things that affect this clamping force? Being stable, what causes the screw to get loose? What are the reasons for the screw to fracture? What are they? Well, one is the metal composition of the screw. Two, abutment design. Screw diameter. The torque magnitude, how much we torque. The thread design. The torquing sequence, we torque once or twice. The screw length. The surface condition, being wet or dry. What? Load angle. The elasticity of the bone. The manufacturing tolerance. The anti-rotational feature of the implant. The platform diameter. The thread number. Very simple, right? The screw head design. The crown height makes a difference. The implant location, being anterior or posterior, makes a difference. The implant angulation makes a difference. The overload makes a difference. The component fitness. Now, shall we talk about all this? How much time we need to talk about all this? Now, I think if I try to add more, I can add more. Now, all of these factors playing a role in the stability of the screw makes it extremely difficult to find specific parameter or advices to tell the dentist what is causing this abutment screw to get loose or broken. And in this literature review, 57 studies were reviewed, and the conclusion was there is limited consensus on the optimal procedure to minimize abutment screw loosening in implants. So I cannot talk about all this. And the more you read in the literature, the more confused you will get. So what I will try to touch is basically on few things, very few things, that are in our hands. Now, the major thing, or maybe the biggest thing that is in our hand, is the amount of torque we apply to the screw to stabilize the system. And what do we use to torque the screw? The torque wrench, right? Now, first we need to understand what is torque. What is torque? Anybody knows? The word torque, what is it? Just rotation? Yes? Well, basically, torque is the measure of the force that can cause an object to rotate around an axis, and it's measured in a Newton centimeter. Now, we know Newton is force, right? So it's the amount of force we apply to this torque wrench to cause a rotation. But what is centimeter? Why we are combining the force with the... It's not the amount, no. It's basically, it's a measure of the distance between the rotating part and where you apply your force. This is how they measure it. So, if you apply the force at this point, in the middle of the shaft, it's different than when you apply the force to the end of the shaft. And this is why they make these indentations, because they want your finger to go here. So, the 30 Newton centimeter that I have to apply here is going to be consistent. Just a little back in history. The concept of torque comes from the very famous Archimedes. And his very famous quote that if you give me a lever and a place to stand at, I would be able to move the earth. What does he mean by saying that? That if you give him a very long arm, his force will be magnified. And he would be able to move whatever object he wants. And this is the same concept that you see in mechanics. When they try to stabilize a screw to hold things together, they would find a torque wrench with a long arm to give more force or more torque at the same given force. Now, how much torque we should apply to stabilize our implant abutments? Basically, the consensus, we need to apply almost 75% of the value that would cause a permanent deformation of the screw. So before our screw gets damaged by 75%, this is where you should stop. And it's usually between 20 to 30 Newton meter, depends on the system. So if a torque really holds the system together, is it a good idea to over-torque a little bit to hold the components together? Why not? Because? Deformation? True. Too much torque would result in a permanent deformation of the screw, reducing its ability to hold the things together. So even before breaking, even if the screw is not broken, there's some kind of plastic deformation that would happen inside that screw. So it would not have that elastic effect or that spring effect wanting to come back together. So if you just try to imagine yourself stretching this spring too much, what would happen? It would just deform. It would deform. It doesn't want to go back. So this is what happens if we try to over-torque. Because I know some dentists, they try to over-torque a little bit to keep the things together. Now, it might stay together for a few days, few months, few years, but eventually it will fail. And not going too much into this stress-strain diagram, but just trying, for some of you who studied this before, if we try to stretch the system or the screw or whatever thing is, the more we stretch it, the more stress or load is building up inside that screw. But there is a point which is right here, exactly right here. This is what they call the yield point. After this point, more stress is being built inside of the system, but this kind of stress is not elastic anymore. So the screw doesn't want to go back to its original shape. So it doesn't hold components together. And eventually, it fails. Now, screws made of different materials act differently. A gold screw is claimed to being able to have a higher preload at the same given torque value. Meaning, if you torque to, I would say, 25 millimeter, an abutment screw or a gold screw, gold tends to want to stretch a little more. So it would theoretically and maybe clinically hold better than titanium screws. However, titanium screws, they are much better in tensile strength than gold screw. What does that mean is that it tends to be more forgiving. So a higher load can be given to this screw without fracturing. In the case of gold screw, it would tend to go faster into a plastic deformation or a catastrophic failure. So, is one better than the other? It's debatable, at least. What companies try to make is a hybrid between a gold screw and a titanium screw. So they took the strong titanium, and they coated it with some kind of a material, trying to lubricate the system and make the screw being able to go further into the implant, stretching more, holding things together. Typical coating can be either gold, tungsten carbon carbide, or nitride. It is claimed to have a higher preload at a given value, and it's claimed to have a high tensile strength. Now, once again, take this with a grain of salt. I don't know if this is all true. If you read the literature, you'll be so much confused. What is better than the other? What is a fact? This is something not debatable. We have a phenomenon which is called the embedment relaxation. Embedment relaxation. Embedment relaxation is well, maybe I need more, but it's okay. It's basically the settling effect. When two parts come together, when two parts get compressed against each other, there are some irregularities that gets flattened out. So once you torque the system and these parts get compressed together, the screw starts to get looser, because if you just imagine yourself holding something between your two fingers and this thing in the middle gets smaller and you're holding at the same distance, you get to lose grasp of that component, right? This is what happens. The two systems comes closer together, so the screw tends to lose some of its preload. So embedment relaxation is very important in our work, and the general recommendation is to retorque at least after 10 minutes, because some of the preload is lost, and watch the star. Now, I would repeat this maybe more than one time, 2 times, maybe, I don't know. Another factor is the shape of the screw, being flat or a little bit of a conical shape. There are some companies who are claiming that their system is more superior because they created a conical head screw. Now, there's an explanation to this, which I don't have to explain. But the literature actually tells us the opposite, that a flat screw head is better. Repeated closure of the screw. If we re-screw 1 time and unscrew, screw, unscrew, screw, unscrew, what happens? Sometime a deformation happens, sometime fatigue happens. So the idea is, if you get an abutment from the lab with a screw being used so many times, or if you have a patient coming back multiple times with a screw loosening, try to use a new screw, because most likely you tend to lose preload in that screw because it's damaged. Screw lubrication. Some claim that they can lubricate the screw to be able to get higher torque. Is it a good idea? This is the single subject that nobody would agree about in the literature. Some would say yes, and some would say no. Now, the idea is that so many of the force that you apply to torque the system together, so many of the force is lost due to friction. Friction here, friction here, friction here. And only very small part of the force is going to stretch that screw. So the initial rotational force, 90%, some literature say 90% goes to friction, and only 10% goes to the preload. Now, the idea of lubricating is to reduce the amount of friction, which leads increasing the amount of force that goes directly to the screw for a higher preload. Once again, does this happen in reality? Nobody agrees. What is this? Anybody recognize the name? Loctite? Nobody? It is some kind of a super glue, but it's not any super glue. I am the kind of person who likes to fix things at home usually. And I remember one day I was trying to fix our laundry machine. So I got all the parts together, and then I found that screw with a yellow thing being painted on it. So I was wondering, what is that? I really didn't know what's that at that time. So I tried to search because I want to put my laundry machine back again. So when I read the manual or the repair manual, it mentioned that I need to put a thread locker to the screw to prevent it from getting loosed under vibration. Now, wow, that came to my head. Why don't we do that to implants? So this is basically, and it's defined under the company's website. It is an anaerobic adhesive thread locker. What does it mean by anaerobic? This super glue specifically gets hardened in the absence of oxygen. This is how it gets cured, in the absence of oxygen. Now, wow, this is nice for implant as well, right? So the thread locker is being used intensively in many fields. So can I use it for my patient? Can I use this? Why? Well, it is retrievable. If you go to the website, it is retrievable. I think we cannot use it because it's non-medical, right? It's non-medical. Well, to my surprise, I did a little search, and I found 2 glues made specifically for implants. If you go to Preet website, they have the Noble Grip, they have the Secabond, and it's described that you can use it for implants. So I ordered one of these. I tried it. Does it work? I don't know, because I tried it a few times. Not all my components get loose anyway. So does it work? I don't know. But at least it's a tool I have in my drawer. So maybe one day I have a patient with a repeated screw loosening that I might try this with him. Is there a literature on this? Well, I just found 2 articles supporting the idea of thread lockers in implants. And they seem to go with a positive outcome. It's a very limited literature nonetheless. Torque wrench, they come in 2 major varieties, spring type and friction type. Now tell me, oh my God. Do you think one is better than the other? Is one better than the other? Spring? This one? Friction, anyone? I mean, sorry, I don't have time to explain what's the difference between the 2, but I assume that you have experienced both torque wrenches. Now, the literature is slightly in favor to the spring type torque wrench. Slightly, not by much. What is more important, however, the ISO, the International Standard Organization, for any kind of torque wrench, they recommend that they need to be calibrated at least once a year, at least. This is in case if there is no contamination or extreme heat going to these torque wrenches. Now, they are not talking specifically about implant or dental torque wrenches. They're talking about torque wrenches in general. So they recommend if there is extreme heat or contamination, they need to be calibrated more often than once a year. Now, guess what? In implant dentistry, we have contamination all the time. We have extreme heat during sterilization all the time. Do we calibrate our torque wrenches? Well, unfortunately, I don't. I don't think anybody does. So I think our torque wrenches, they don't give us exactly the right value. So my recommendation, if you cannot calibrate them, and I think you cannot because we don't have the right tool to calibrate them here, is to replace them every once in a while.
دكتور اعتذر منك ادري باقي لك وايد معلومات بس we need to
Well, just
shorten
give me
time.
maybe 5 minutes or so.
5
You
more
want me to
minutes?
stop?
I think they're waiting for the iPad question. That's
Yeah, I think, this is why I kept an idea. I'm close to finish, basically. So, despite all what we try, we experience screw fractures. And anybody who did implant, I'm sure he experienced screw fractures. And the only thing we can do about them is to retrieve them safely. So if there is something that I would recommend for anyone who's about to decide which implant system to use, try to use a system that has a special kit to retrieve these broken screws, because they happen. It happens. And if an implant company comes to you, and if you ask them, do you have a retrieval kit for a broken screw? And they say no, you tell them, goodbye, sorry, I'm not going to use this system, period. Because broken screws happen. And these are beautiful tools that helps you remove a broken screw without damaging the implant. What's even worse than a broken screw is a broken implant or a broken connection. This is where the whole thing dies. And because I tend to like to use any implant system that offers me to use their system, I have seen a broken implant with almost all implant companies. I don't think there is a single company that can claim their system doesn't break. They all break for one reason or the other. Now, why they break? If there is, there are a few reasons why they break, but an important reason why they break is the diameter of the implant. Flashing star, right? So, a narrow implant tends to break faster than a wide diameter implant. Why? Because wide diameter, they have thicker walls. Thickness affects strength. So, I wouldn't use this implant in a posterior region, period. Corrosion. Corrosion fatigues metal. Do we have corrosion in titanium? In fact, we do. The literature is full of this. Now, what's the real significance of corrosion? First, we need to understand we have not only one type of corrosion, we have multiple types. We have the galvanic corrosion, the pitting corrosion, fritting corrosion, stress corrosion, crevice corrosion, and microbial corrosion. They are all available in implant dentistry. They all happen. And with time, they all can affect the strength of the implant. Titanium grade. Maybe 1 minute, huh? Titanium grade. During the manufacturing of titanium implants, we basically have 5 major grades of titanium. And I say major because there are some other companies who come with a slight variation to this. We have grade 1, 2, 3, 4, 5, and we have a flashing star. Grade 1 being the weakest, grade 4 being the strongest of the commercially pure titanium, and then we have the titanium alloy being the stronger of all of them. So titanium alloy is stronger than all of these commercially pure titanium. Well, if it's stronger, why don't all implant companies use it? In reality, most implant companies today, they use grade 4 titanium. Most implant companies, they use grade 4. Very few, they used to do grade 2 in the past, but they were breaking. But very few use grade 4. So why not using grade 5? Corrosion was one topic. It is claimed that grade 5 tends to corrode faster or more than the rest. Toxicity. Well, something is happening, huh? Toxicity. The theory is that titanium alloy, they tend to leach some aluminum particle into the human body, and it's toxic. The debate is similar to the debate of amalgam. They say amalgam leaches mercury into the body. Now, how significant is that? I think the literature is against it. I think If you are a scientific person, you will say amalgam is safe. If you read the literature, I think titanium alloy is safe. But marketing has a role to play into this. The real reason is they're not using grade 5 is cost. Grade 5 usually is more expensive than grade 4. And if you try to sell a system with a titanium alloy, usually it is more expensive. Now, to the most part, grade 4 is fine. Well, after all this, what's causing failure really is load. After corrosion, after thin walls, after whatever, what's causing the things to fail is overload, right? So we need to find a way to protect the system. And this is my last 1 or 2 slides. How do we protect the whole system at the end? What's the difference between the right and the left? The rights are splinted. I mean, the left are splinted, right? The right are individual. Correct? Any other difference? Platform switch. Any other difference? Huh? I don't know about this. I didn't measure them, so I don't know. Getting close. Because we are out of time, it's internal connection, external connection, right? They used to have more external connection in the past, so they used to have more screw loosening in the past. So the literature was in favor of splinting implants together in the past because they used to have more screw loosening with external connection anyway. Now, with internal connection, do we have to splint? Our judge is the literature, right? So, reading the literature, is it in favor of splinting or no splinting or no difference at all? The majority, the bigger majority of the literature today is an advocate of no difference. If you splint or don't splint, they would function the same. Mechanically and biologically. No difference. But there is a very slight amount of literature which is in favor of splinting still, claiming that it is better for stress distribution. It is better for screw loosening, but it is a minor favor. Is there any single article that favors non-splinting? Any single article saying non-splinting is better? There is no single article that claims no splinting is better. So, would you splint or would you not splint? Not splint. Why? I think maybe it is easy, maybe it's not easy. Because you have to adjust the contacts more, right? Huh? Yeah, the length. Usually, in full arch, I tend to segment my restoration, not splint everything together. So it is a personal preference at the end. If you want to say, I don't want to splint, and I'm backing my opinion by literature, you're wrong. The literature says there is no difference. However, the most recent meta-analysis I found on this subject, it looked at 19 studies, 4,000 implants in 2,000 patients, a mean follow-up of about 7 years. Again, it found no difference regarding bone or prosthetic complication, but they found higher survival rate for splinted implants. Now, this sounds strange because say there's no difference, but it said there's an implant failure, more with non-splinted implant. The thing is, they studied, it was a quantitative study and qualitative studies. When they look at quantitative, they look at numbers. When they look at qualitative, they look at reports. So they found more reports about the survival rate difference between splinted and non-splinted, but there's not actual number. It was just noticed that they have more implant failures with the non-splinted implant. So I favor splinting to an extent. Some favor non-splinting. I think both are right. The last one, going back to this picture. Who this guy is? The taxi driver, right? He died with his implant in his mouth. You think why? The knowledge was minimal at that time, right? The whole knowledge was primitive. Well, the implants are splinted, right? Original design for implants are to be splinted. How much did we improve from this? I don't know. But again, implants were originally designed to be splinted. Should they be splinted today? It's up to you to answer. So, to end things up, I think the decision of what implant system to use is not always basic on scientific literature, is not basic on clinical findings. Sometimes they are on very irrelevant things. I know some people, they like to use the implant because the surgical kit to use is easy. It's an easy surgical kit, so I like this system, I want to use it. It's irrelevant to the success, right? There are some people who would like to use that system because the company is helping them. It's offering good support. So the decision is not really basic on how good the implant is. Some people, they love a system because of a silly thing like this. What do you see in this screwdriver? What's different about it? You notice something? Oh, very small little red dot. What this is for? It just helps pick the screw up easily. So someone might like the system because it helps pick up the screw easily. So my advice to you at the end is use your screw wisely. Thank you for the time. Sorry that I'm running late. I apologize. And Allah يسلمك. At the end, I promised you there is a single happy person who will win
يعطيك
the
العافية
iPad.
دكتور.
ما أدري أبو ولا لا. Okay.
دكتور بس نحب
Yeah, أكيد. Anybody? Any question? You just want the iPad? تفضل يا دكتورة.
شكرا جزيلا، المحاضرة أكثر من رائعة. أنا
الله
بس
يخليك.
سؤال واحد، مثلا في الأول أون 4 بيريكومند إن إحنا نعمل تورك 15 لكل الأباتمنتس، أنا عايز أعرف ليه؟
Why 15? Because the screw that they use is not the actual abutment screw. It is another level of screw. Usually it's a smaller screw that holds the system together. In all-in-4, they use a multi-unit abutment first, which is the actual thing that goes inside the implant. That one you can torque up to 30 maybe, or 25. But the screw that holds the system on top is a much smaller screw. And this is just holding the prosthesis to the multi-unit abutment itself. And in general, when using a splinted restoration, we tend to screw to a lesser amount. In general, if we splint a full arch restoration, usually if the recommendation is 30, at 20 usually we'll hold things together just fine. Any other question?
في أي سؤال؟ another
لأن أنا عندي
question
سؤال.
قبل المسابقة.
Yeah, I have a question for the iPad.
For who?
I have a question for them.
Okay.
Let's be one more question.
السلام عليكم ورحمة الله.
السلام ورحمة الله.
Thank you very much, Dr. Bahrani, for.
صوت مو واضح. ها؟
Thank you very much for this very amazing presentation.
Thank you. Thank you.
And here is an open invitation for you to present in Mecca International Dental Conference next year.
It's my pleasure, my honor. My honor.
Really, I liked your presentation, and I liked the heavy experience that I can see it, which really we need it in our community among the general dentists who are working with implants. That's the type of presentation that we are searching for, actually. Thank you very much. And I have a very small, maybe strange question. Do you have any differences between male dentist and female dentist in torquing?
Well, with torque wrenches, no. I mean, in the past, when they started to restore implants initially at the early days, they used to use just hand screwdrivers at that time. And that was one of the reasons they experienced screw loosening, because the hand would just give maybe about 10 Newton centimeter. But with torque wrenches, I think even if a 5-year-old baby tried to use it in a correct way, they would experience the same thing.
Thank you, thank you.
Thank you. No, if you're doing 30 multiple ways within like few minutes, it doesn't make any difference. However, if you torque to 30 and patient comes back after 1 day, and then you torque to 30 and it moved, and patient comes next day and you torque again and you notice that it's moving again, it means something is wrong. You are really stressing the screw. So you are getting 30 and 30 and 30, but basically the screw is getting stretched. Maybe it's losing a point of a permanent deformation, maybe. But if you're doing 30 multiple times within a short period, no, you're getting the same amount of torque, basically. So can I do my question now? Now, please, because I don't want to create a chaos here. If you think you know the answer, just please raise your hand, and we'll give you the mic. And the first one who's going to answer it is going to get the iPad. It's not a difficult question. It's something I mentioned during my presentation. But it's just a question that maybe some people didn't pay attention. They will lose it. Sorry. And the prize or the iPad is given by the Ostim or Royal Pedia Implant Company. The question is, what is the name of the phenomena that describes the settling effect of a screw during or due to flattening of compressed surface? So when we screw, things tend to...
Pigment.
I said I need a hand. هذا أول إيد شفتها. Again. Embedment. Embedment. Congratulations. تفضلي دكتور حياة. لا كيف خلق تستاهلين كل خير دكتورة. ما كيف على البركة. Thank you so much.
شكرا وايد على
الله
المحاضرة.
يسلمك ما قصرت.
ونحب نسوي لك تكريم بسيط على جهودك بهذه المحاضرة.
يلا حياك. انت اللي سامحنا بس ضغطناكم شوي.